Are we ready? Can we start with Dr. Ajit Puri? So the first is, all of us have various techniques of doing thrombectomies, and the whole idea was the first presentation can be a standard technique. What in the master's hand is the standard technique? So Professor Vincent will be presenting, Ajit Puri. Ajit Puri is online. So I think, yeah, we can get Ajit online and play the video made by him. What is his typical way of doing thrombectomy? Yeah. My regrets. We have chairpersons, Matthew and Atula. Please come over. And Vivek Gupta.
Curriculum and faculty, honored to be presenting. I wish I was back home at my old stomping grounds in New Delhi, but due to some unavoidable reasons, I am stuck in Boston, so here I am. For guys who don't know me, my name is Ajit Puri. I was Amesonian, but now I'm at UMass for the last 15 years. I'm a professor of radiology, neurology university, and I thank Professor Wilson and Dr. Gupta for inviting me. I've been asked to talk about stroke and what is my setup. I'll briefly talk about my strategy for NVO now and vivos. If we have time, I can talk about primary and secondary vivos and vivos also. Just very simplistic, my approach has changed over the last 3 or 4 years. When we started doing this, I was a belt and suspender guy. I used to do a balloon neck catheter. I used to do an aspiration catheter, a stent retriever, basically caught the clot between the stent retriever and an aspiration catheter under balloon arrest and under balloon reversal to reversal. I used to pull everything out. For me, things changed about a couple, 2 to 3 years ago. In my own lab, we did some research on the super large bore aspiration catheters like 088 and above. That's when my strategy changed, and since then it has changed slightly, but in simplistic terms, it is super large bore aspiration catheters. If I can get that catheter as far as I can get it, I would try that as my first line. So for carotid occlusions, pseudo occlusion, T occlusion, MCA up to and including proximal bifurcation and trifurcation, my setup is very simple. I'll put a 9-French sheet about 23 cm, the base catheter, which is an idea of 107, which is almost like an 8-French sheet for people who don't want to put a 9-French sheet because it becomes off-label for closure for ANVI. You can always do a direct access with a base cam. Then I use a 088 catheter, which is called high point, and inside there is a leading catheter called tensing. Very, very rarely I need to put a micro wire outside that tensing insert catheter, but almost 80% of the cases I'll probably be okay to go in with a tensing. It's a very atraumatic catheter, and I'll show you here. Let me show you a video which I can fast forward for the time's sake. Here is a case of an elderly gentleman. It's at 10 o'clock at night. So I'll probably have a stiff wire because these catheters are stiff, so either a glide wire advantage or a stiff glide. I'll use that to bring up a Berenstein or a hockey shaped catheter and then bring up this base cam. This is almost akin to an 8-French sheet. In most cases, I think leaving it in the distal common or very proximal ICA does the trick. Okay, I'll see if I can just fast forward this a little bit more. At that time, we'll do a run, confirm that we have a large vessel occlusion and the vessels are big enough for us to put an 088. And usually, when I initially started doing 088 about 3-4 years ago, I would probably just measure the MCA to about 2.3, 2.4, make sure it does. But now I think you can eyeball it and you should be okay. And this is my 088, this is my 107 base cam catheter, and here comes the 088 with the tensing. So it's almost like a monorail system, like the 088 system is a catheter on a stick. So it's a super large aspiration catheter and very atraumatic even without the wire. Although I have a wire loaded in, you can see the wire loaded in here. Then I'll just climb up a little bit with the base cam to provide some support through the virtuosity. And then you can see how this very seamlessly finds the MC and then basically will clot, the tensing and bring up with the right hand, just like any carotid procedure, bring up that O88 catheter of choice. I mean, there are so many of them coming now in the market. Perfuse has a millipede, Sophia has a Sophia Max 088, this is a Group 92 088. There is an O92 coming to market also. Probably next month we'll have access to the O92 catheter also. So this actually simplifies the procedure a lot. So here you can see the O88, and you can probably see it put back, how it kind of climbs up on its own. You can see once I let go of the O88 and pull the tensing back, it will probably passively go in forward. So remember that space which the tensing was taking, now that is now, because of the law of conservation of mass, that space is now taken in by the clot, and the clot has gone inside the O88 over here. At this point of time, you can see we are at 10:03, it was a simple catheterization. Then we just wait for 2 minutes, and I'll just fast forward to that 2 minutes thing, and you can see we are going live tracking over there while the aspiration is going on. And I'll just fast forward even more, and you can see how when the 2 minutes are up, then at that time, under aspiration, we just put it out. We can now we put it out under aspiration the whole thing. Almost at 2 minutes. And now we're putting this out under aspiration. You can see how the flow starts working, and under aspiration, just keep an eye on that 8 French catheter / base cam that it does not go through very high. Sometimes I've taken it higher also if the situation demands for it. And at this point of time, we'll just do the regular, just aspirate through that base cam and aspirate through the base cam / 8 French shuttle, clean it up, and just do a run at that time. And you can probably see the run now. And you can see a little bit of spasm there when the base cam went up, but the MC is not open. We do a run in the APN lab to make sure there's no. And this is a live clock running right now. So this is my simplistic access to an LBO. Let me jump back. This is how it looks when you look at the illustration. That's the base cam, which is 106 extent corrected. A high point, which is a catheter on a stick with a tensing aid. And this is a seamless, like how it goes between the clot and the vessel wall. And then once you're at that clot level, you can just put back the tensing and the O88 climbs up on it. The good part which I really like about this kind of system is that it basically does not let you break the clot. Like the clot, you don't need to cross the clot to bring the O88, and a lot of other assemblies I've used, sometimes you just have to cross with a tower of power with another 70 catheter, another 50 catheter, another 24 wire to cross it. But in this case, you don't need that. Even with severe tortuosity, that's not a problem. See, there's a 360-degree loop in the IC, and then still that O88 with all these loops goes very well and opens up the IC tendons. And I think for anything from MCA, bifurcation all the way to chronic, this does a really good job. I'm at 8 minutes, so I'm going to stop, not talk about viewers, but I can probably discuss that. And thank you again for giving me the opportunity to talk about this. My strategy for you. I'm happy to take any questions.
Hi, thanks a lot, Ajit. That was a very nice case selection, perfectly the way we want it, and you showed your technique. So, Dr. Matthew, Atulab, and Vincent is here. Any comments, any questions you'd like to ask? Is that mic working?
Yes, so like we all realized that finally when the large bore catheters come, stent retrievers practically going to go out of the market, and I think in India we're just waiting for the big ones to come in. We are still stuck with the Vecta 74, that's the largest we have. But absolutely I think we're going to have a total new way of treating clots. Like you said, don't break, we aspirate them fast. For first pass aspiration is going to be the answer. And the big amazing thing is we all have been practicing for 30 years. We never could imagine these big catheters could ever go up, And there was an era when we used to take, 45 minutes taking a micro up. So It's phenomenal technology, actually, when I just look at it to imagine. And once we wedged the vessel and we got this stuff, I think that's what everybody knows, that this has been a revolutionary change. We have to give credit to Penumbra, who started the first aspiration catheter, never believing it would work so well.
Absolutely, you are 100% right now. So I remember, like, even in the fellowship days, if we put a 5-inch catheter anywhere above the distance circle, we used to get a slap on our hand, like, whoa, this is too high. We were like, and then now when we look back and look forward, doing O88 has become routine, and our fellows are doing it routinely, and then we're talking about O92s, putting O92s in the MCA very soon. So the technology has moved in leaps and bounds. What I have seen is, I was a stent we used to do 250 of these a year, but in my lab now with this O88, I think I can count on one hand the number of times I have to put a stent retriever out now. That's how effective these super large bore aspiration catheters have become, and I think with the technology moving and more players coming into this market, and competition is good. I mean, that's the good part. I think it's very, very difficult to have a clot which can sustain this kind of an aspiration lumen. And the key which we see in our lab and in our patients also is ingestion. Like, it's very, very rare that you have an O88 catheter which is fully plugged and no blood is coming. Maybe in a carotid occlusion where there is clot from all the way from the cervical IC to the MC. But apart from that, with that big of a lumen, and remember this is a catheter on the stick, so you're basically aspirating from the 8-friend shuttle approximately. So it's very rare to clot to not be able to come up with this super large bore.
Great. I think
if I can just ask, sir, I mean, earlier Penumbra catheters, I mean, the problem was kink. So this catheter, it's like dual braided, or I mean,
Construction.
yeah.
It's a very unique catheter design. It's actually not a full length catheter. The catheter is only 62 cm. So the very floppy catheter is only 62 cm and is connected to a wire which is 120 cm. So the whole catheter is about 160, but the actual catheter is only 62 cm. Because you have an 8-foot shuttle or an equivalent size catheter called a base cam, so the base cam becomes your conduit proximally, and this O88 is just a very floppy noodle which goes into the brain. So from the brain, from the MC, you're putting in the O88. In the cervical IC, that O88 becomes 107. So that's why you have almost like a big funnel coming out. From O88 is the smallest and 107 proximal is the biggest. So the way they have done it with the catheter on the stick, you don't need 132 cm, you only need 62 cm.
Yeah, I think what we have seen, Ajit, is the glimpse of one of the possible futures, and I think maybe whether same size will go into smaller Indian arteries, but I think we can always adapt to smaller sizes, and this is one of the future options clearly. And really thank you to show this case. I would love to hear more about MEVs and all, but I think we'll hold a one-day whole stroke meeting. Today we have stroke and aneurysm, so we had limitation of time. But I really want to thank you for logging in from US and sending a terrific video, and look forward to having you here next time. All right? All right. Great. Thanks a lot, Ajit. And so, as I said, one of the possible futures, what we are looking at